Facial danger zone 6 can be located by identifying the following points. The mid-pupil. The second mandibular premolar. A point on the anterior maxilla 1 cm below the infraorbital rim. A circle with a radius of 1.5 cm is drawn around this point to include the infraorbital foramen. Facial danger zone 6 includes the infraorbital nerve, which is a branch of the second division of the trigeminal nerve, cranial nerve V. The zygomatic branches of the facial nerve also run through this area to innervate the levator labii superioris muscle. Injury to this nerve creates numbness of the lateral nose, maxilla, cheek, upper lip, and inferior eyelid, that can interfere with a patient's ability to eat. Injury to the nerves in facial danger zone 6 is unlikely to occur in the typical subcutaneous or sub-SMAS facelift. This nerve may also be injured in the course of rhinoplasty, injection of local anesthetic or facial fillers, and mid-face advancement surgery. Facial danger zone 7 is described by a circle with a radius of 1.5 cm around the mental foramen. The mental foramen lies on the mid-mandible below the second premolar along the line drawn through the supraorbital foramen, mid-pupil, and infraorbital foramen. Facial danger zone 7 includes the mental nerve, which is a sensory branch of the third division of the trigeminal nerve, cranial nerve V. Injury to this nerve results in numbness in one half of the mucosal and cutaneous surfaces of the lower lip and chin. A mental nerve injury is a serious clinical condition, because patients may have difficulty holding food in their mouth and can inadvertently bite their lower lip during chewing. Injury to this nerve occurs most commonly in the course of chin implantation surgery when dissecting a subperiosteal or preperiosteal plane, through either a buccal or submental incision. Conclusion. Serious permanent injury to the peripheral nerves of the face is, fortunately, uncommon. Dissection should be carried only in the subcutaneous plane and does not penetrate the SMAS layer, then, it should be impossible to damage the motor branches of the facial nerves. Practitioners using endoscopic and injection techniques must be aware of the locations of danger zone peripheral nerves to avoid injuring them. The care of the patient with a facial nerve disorder starts with a diagnosis and ends with patient satisfaction. Neither may be possible, but every effort should be made to achieve both. Whenever possible, surgeons should promptly repair facial nerve injuries in order to restore neural continuity from the facial motor nucleus to the distal facial nerve branches, either through direct microsurgical repair or nerve grafts. There are several, well-defined areas or zones in the face where the important motor and sensory nerves have a predictable path. Mapping these danger zones out before surgical intervention, using bony landmarks where possible, helps orient the surgeon during dissections of the face and neck and may reduce the incidence of significant complications. The most feared complication of facelift surgery is catastrophic injury to one of the major facial nerve branches. Injury can result in permanent facial deformity, numbness, dysesthesia, and pain. Even a limited neurologic recovery can leave the patient with an undesirable aesthetic outcome, as well as discomfort. A thorough understanding of the nerve anatomy is paramount to avoiding injury.